The Senate Committee on Health and Human Services will come to order, and the clerk will please call the roll.
Senator Kolkhorst.
Here.
Senator Perry. Senator Hancock. Senator Hall. Senator Miles. Senator Hughes. Senator Blanco. Senator Sparks. Senator LaMantia.
Members, since the committee is in recess and a quorum was established at an earlier hearing, a quorum will be reestablished as the meeting progresses. I want to welcome everyone here today, and just a few notes, administrative notes for our hearing. There are several committees happening at the same time and occurring, and I know that the staff is going to watch their members come in and out and presenting and doing different things. I too am a member of a committee that is meeting right now, but with that in mind, this is how the day should lay out. This morning we were going to lay out Senate Bill 52, Senate Bill 426, Senate Bill 25, and Senate Bill 26. We will hear the invited testimony and public testimonies for Senate Bills 25 and 26, and we hopefully will reestablish a quorum, and we will be able to vote some bills out before we go to the floor at 11 o'clock. Before we recess, members, at the end of the day, most of the bills that we had already established as voting will be voted out hopefully this morning. It's my plan to reconvene 15 minutes following adjournment of the Senate, and I will make an announcement on the Senate floor as a reminder. Once we return, we will do the remainder of the agenda for today. The committee uses electronic witness registration. If you wish to provide testimony of any kind, you must register at the kiosks located outside of the chamber. Each public testimony will be limited to 2 minutes total to speak on the bills unless members have additional questions. Those wishing to testify or to remain in the Senate gallery until called upon to come to the floor, although there may be a few seats but not many still left around and outside the brass rail. I will call names, several names at a time, and once your name is called, please make your way to the floor if you are in the gallery. Welcome Senator Zaffirini to Health and Human Services again. The chair lays out Senate Bill 52 and recognizes the author, Senator Zaffirini, to explain the bill. And before I do, we recognize Senator Sparks and Senator Perry and Senator LaMantia, who are present, and that establishes a quorum. With 5 being present, a quorum is reestablished. Senator Zaffirini.
Thank you, Madam Chair. Madam Chair and members, Senate Bill 52 relates to the right of state hospital patients to designate an essential caregiver for in-person visitation. Members, in 2021, the legislature unanimously passed Senate Bill 25 by Senator Kolkhorst, establishing visitation rights for designated essential caregivers of persons in nursing homes and assisted living facilities. Senate Bill 52 would extend those visitation rights to caregivers whose loved ones are in state hospitals. Generally, it would require the Health and Human Services Commission to develop guidelines to assist state hospitals in establishing essential caregiver visitation policies and procedures. And it also establishes the guidelines for them. There is a committee substitute, Madam Chair.
Senator Perry sends up the committee substitute. The chair lays out committee substitute for Senate Bill 52 and recognizes Senator Zaffirini to explain the differences between the bills.
Thank you, Madam Chair. Madam Chair and members, the committee substitute differs from the bill as filed originally in that it would clarify that if a patient is a minor, the patient's parent, guardian, or managing conservator may designate both of the minor patient's parents as essential caregivers.
Thank you, Senator Zaffirini. Thank you for bringing this important bill, as you mentioned, building off of Senate Bill 25 from last session, which was tailored towards state-supported living centers and nursing facilities. I understand your bill applies only to state hospitals at this time. Members, do you have any questions for Senator Zaffirini? Okay.
Thank you.
We will now hear invited testimony. Chair calls Dennis Burrell and Mary Nichols. If you would state your name for the record and your position on the bill, and you may begin your testimony.
Sure. I'm Dennis Borrell with the Coalition of Texans with Disabilities for the bill. Madam Chair, committee members, this legislation was born in the pandemic, clearly. So as Senator Zaffirini laid out, she gave the great details, but I would like to explain what our organization experienced during the pandemic, and that is multiple calls from family members, friends of people that were in institutions, in the SSLCs, nursing homes, and yes, sometimes the state hospitals. And what they felt is when the isolation occurred, that they couldn't get in and see them. Now, some of this is like families wanted to see family members, but not all of it. Not all of it. A lot of these people are what I definitely call essential caregivers. And what I mean by that is they are truly part of the care team. They are close to the individuals, but they're able to, for example, interpret what communications are being made by the individual. They're able to talk about history. They're able to provide substantial information for the institutionalized care team to make better care for that individual. So our lived experience is that this was a big issue statewide. This bill is modeled on Senate Bill 25 by Chair Kolkhorst and models a lot of that language. It covers a lot of the bases. I'm just going to talk about some of the things we like the most. The fact that this is essential caregivers. This is not a free pass for anybody to come in. It's strictly essential caregivers. So there's guardrails there. It honors the hospital safety protocols in the case there's another pandemic or epidemic. So we're not putting people at risk. There is a revocation. Say there's one of these essential caregivers that doesn't follow these protocols or doesn't act appropriately, they essentially can be revocated and then replaced by somebody else. And they're really not substituting for hospital care, they're making it better. I'm going to conclude by saying this bill is about care. Thank you.
Mr. Burrell, I could not agree with you more about communication skills and understanding our loved ones or someone that you're a guardian of. And that's not to mention the fact that just the need for interaction with somebody that you know and love or someone that cares for you is extremely important for the overall health of these individuals. And that's why I was so passionate last session coming off of the pandemic, coming out of the pandemic. We weren't quite out of it at that time, but what I heard from people, and my mother was a stroke victim for 11 years and could not walk or talk. And our communication, I could understand what she was trying to say. And I can't imagine, I really cannot imagine. We saw my mother every day in a nursing facility. I have 3 other siblings, and we took turns, but every day, there was not a day that she did not see a loved one. And I can't imagine going a week, but weeks, months, years, and as was the case with some. So thank you for your testimony today. Senator Zaffirini, thank you for this important bill. We'll continue to learn from the pandemic. That's what today is about. Learn from the pandemic to set the annals of history straight for the future, to give a roadmap, to say what we did right and wrong. And one of the things that we have to do is allow an essential caregiver to be a part of that person's life.
Absolutely, thank you. I just say your bill was meaningful, and this bill is meaningful because it closes a gap that we didn't think about back then. Excellent stuff. Thank you, ma'am.
Thank you, Mr. Burrell. The chair calls Mary Nichols. Mary, are you with us?
I don't think she's here, so.
Mary Nichols, founder of Texas Caregivers Compromise, would be for the bill. I know Mary, and she's a great advocate in this area of establishing essential caregivers. With that, members, if you have no other questions, we will leave this bill pending until we take public testimony later in the hearing. The chair lays out Senate Bill 426 and recognizes its author, Senator Paxton, to explain the bill. Welcome, Senator Paxton. And while you're sitting down, Dr. Christopher Regal is an invited witness, and so I hope that he's on the floor. Great, I see you. Senator Paxton.
Well, thank you, Madam Chair and committee members. It's great to see you this morning. In 2015, the Texas legislature passed House Bill 21, known as the Right to Try Act. It allowed patients with certain terminal illnesses to access investigational drugs, biological products, and devices in clinical trials. Likewise, in 2018, the federal government passed the Right to Try Act, which provided a way for patients who've been diagnosed with life-threatening diseases or conditions who were unable to participate in clinical trials to gain access to certain treatments that were available. During the COVID pandemic, some patients and doctors encountered interference in the prescription of off-label medications to combat COVID by pharmacists. As a state senator, I value the concerns that were expressed to me around this issue by my constituents, both patients and doctors in Senate District 8. And I support their desire to protect their right to give it a try when they and their doctor agree. In the spirit of the right to try, Senate Bill 426 is the right to treat, which safeguards the patient-physician relationship. Senate Bill 426 allows physicians the right to treat by protecting their ability to prescribe off-label medication and treatment, which may assist in the treatment and recovery of COVID-19. And I do have an invited witness. Thank you, Madam Chair, and thank you, members.
Members' questions. I think that you laid it out very well on, the goal of letting doctors be doctors. And sometimes I call doctors mini scientists, and they know their patients pretty well. They know what treatments are working, and I think this is a very important bill. Senator Perry.
Thank you, Madam Chair. Just briefly, and there's another bill coming up today that has a similar question. I think pharmacists that do this are willing to do this. I think doctors that are doing it are willing to do it, and I support 100% being a participant in some of those as my 3 rounds of COVID the last couple of years. But the question that some of the pharmacists have had, sometimes supplies are limited, and they want the flexibility to not gatekeep, but at least not expend. So, for instance, I'll tell you, over 60 now, I have medications I never would have thought I'd taken 10 years ago. Sometimes I want a 90-day supply for convenience and just to get it done, and they'll say, well, we only have 30 days of that particular drug today. So I think that what they would like to see in yours, and I know Senator Hall's got a bill that kind of, from their perspective, forces them to dispense all they had at that one time for that one patient, where they could ration it out and still make it a little more inconvenient, unfortunately, but until supplies catch up, they might cover more people. So are you familiar with some of those concerns or had?
This bill is really not tailored at addressing rationing or anything like that. It literally, and when you hear the testimony of the invited witness,
right.
You'll see that the intent of this bill is just to remove the barrier of the pharmacist getting between the patient and the doctor.
And I think I get it, and I agree with it, and Senator Hall's is a little more direct. We just want to make sure that the pharmacists have the ability to make limited supplies last as long as they can. I knew that wasn't the intent to restrict or force people to dispense, but I just want to, as we go through these conversations, there's just a practicality, especially with those particular over-the-counter medications. There were supply issues, right? And so it put them in a real dilemma of how much and how do I have to do this. So I appreciate the bill. I just want to make sure that we're practically speaking, those guys have a reality check of, we've got 50 people in line. They all want 90-day supply, but if I give them 30-day supply, I can get all 50, so
sure.
That type deal.
And there's nothing in the bill that I think would interfere with
Perfect.
With that kind of decision-making.
I appreciate that. I didn't see it, but I wanted it on the record.
But certainly, I think our intent would be the same. Senator Perry, thank you.
Any other questions for Senator Paxton? The chair calls Dr. Christopher Regal.
Hello, thank you for having me. My name is Christopher Regal, MD. I'm a board-certified OB-GYN doctor, trained at UT Southwestern Medical School and Parkland Hospital in OB-GYN. I also served as a expert consultant for the Texas Medical Board for most of my career, and as an expert medical witness in the U.S. Supreme Court case Stenberg v. Carhart. There are many medications that started off for one purpose and went to another. I've got a few to mention here. Viagra went from being an antihypertensive to being an erectile dysfunction drug. Metformin went from treating adult onset diabetes to helping women with PCOS be able to ovulate on the medication and have pregnancies. Wellbutrin went from treating depression to treating stopping smoking, and propranolol went from being an antihypertensive to treating performance anxiety. So there's lots of different drugs that start out for one purpose, and we recognize that they're good for other purposes as well. So I was in New York City when COVID exploded in February of 2020. We didn't know that at the time until we got back home. Fortunately, none of us got that. But when we got back home, I started doing some research into COVID and what was going on with in Europe. And I noticed that COVID was also 98% related to SARS. So I did some research on that and found a study from 2005. And since the problem with COVID was having what was called a cytokine storm, which is an over-exaggerated immune response to the virus, it seemed that it was an immune problem, and there was a drug being used for autoimmune problems, lupus and rheumatoid arthritis, which was hydroxychloroquine, and I thought it'd be a good idea to look into that. So I actually phoned a few patients, and I filled a couple of prescriptions for hydroxychloroquine in late March of 2020. But by April of 2020, when I called the pharmacy, they asked me for the first time in my 30-year career at that point what the diagnosis was, and then they rejected the prescription. And I just found that was very unusual, seeing it's the only time it happened in my entire career. So.
Go ahead and finish your thought, and then if we have any questions.
I just feel like if there's a drug that is completely safe, like hydroxychloroquine, has been found to be safe for over like 80 years of use and 40 years by Dr. Daniel Wallace out in Los Angeles at Cedars-Sinai, it should be able to be used for other purposes when it's available. And that was my only point. There's lots of research showing that hydroxychloroquine would have been helpful in treating COVID, but it wasn't available.
Doctor, I'm going to ask a question. Was it not available because of supplies, or was it not available because people, whether it's the medical boards across our state, different states, or pharmacists who refuse to fill? What's the answer?
I understand the supply issue. When I was prescribing it for patients, it was no supply issue whatsoever. But I heard in a press conference they were going to ramp up production to treat 29 million people is what I heard. And then we were unable to get it anymore. In fact, I had a pharmacist who's also a friend call me and tell me not to prescribe it anymore because they were supposed to turn us into the Texas Medical Board.
Was that a physician, doctor?
I'm sorry?
Was that a I'm sorry,
it was a pharmacist. A pharmacist who's also a friend told me not to try to prescribe it because I would be turned into the Texas Medical Board.
Very interesting. I really am, it's perplexing why we did not try to use, as you say, ingenuity and try everything that we could to save lives and to, as you say, thwart the catastrophic events that would happen if COVID progressed. And so thank you for your testimony today. I'm hoping that, again, I view our job or our mission or effort to set the record straight for anything moving forward. Is hydroxychloroquine, I know that some said it had some heart effects.
No, like I said, Daniel Wallace in Los Angeles at Cedars-Sinai, one of the top people who treat lupus in this country, and hydroxychloroquine is used primarily for rheumatoid arthritis and lupus, both immune disorders. He said in his 40 years of use with his patients, he has never had any problems at all.
So was the thought when, I know at the very beginning when hydroxychloroquine was being used, there was a thought that those that used it for lupus or the other diseases would not have the availability, and so that's why they curtailed it. But as the supply chain caught up, did you see that as...
No, we were, well, first off, once I was told that I'd be turned into the Texas Medical Board if I prescribed it anymore, I stopped prescribing it, but I know that for at least a year following that, regardless of production, we were told we couldn't prescribe it. But in the press conference that I heard on 3/19 of 20, they said that they were ramping up production at that point for millions and millions of doses, and that the pharmaceutical companies could handle it. So
did other countries use hydroxychloroquine successfully or unsuccessfully?
I'm sorry, I didn't hear the first part.
Did other countries use
Yes,
hydroxychloroquine?
many other countries around the world used it successfully.
Could you name a few?
Well, there's a researcher named Didier Raoult in France, who's a world-famous virologist who used it extensively, and they did many studies, but my understanding is it's been used all over the world. I believe Australia had a study in it as well. I can't, off the top of my head, I didn't write them all down, but it's been from all over the world.
And lastly, have you ever experienced anything where you were threatened because you prescribed a drug that you would be turned into the medical board?
Never before this.
Thank you. Members, any other questions? Thank you. I believe, members, that's all of the invited testimony at this time. Thank you, Senator Paxton. So we will leave this bill pending until we take up public testimony later in the hearing.
Chair lays out Senate Bill 25, recognizes author Senator Kokhorst to explain the bill.
Thank you, Mr. Chairman and members. I have to say, and thank you to the 26 Senate joint authors on this bill as well. Senate Bill 25 is a part of a comprehensive package to dramatically increase funding to nursing education and training programs, including those addressed in Senate Bill 25. It revises and amends an existing scholarship and loan program in statute from the 71st legislature that has not been funded in many, many, many years. It expands the faculty loan repayment program to include part-time faculty. It changes the faculty loan repayment amount from a cap of $7,000 annually to a figure to be determined by the Texas Higher Education Coordinating Board, enabling more funding to be provided. It extends the Nursing Innovation Grant Program until 2027. It removes the matching funds program from statute because, members, the program became underutilized and somewhat cumbersome. The goal is to dedicate more funds directly to scholarships for nursing students. As we all know, the purpose of this bill will help address the nursing workforce shortage. It is a priority of Lieutenant Governor Patrick, and I'm grateful that he allowed this to come forward. And this was also for the returning members of Health and Human Services, which 3 of them sit right here and were very good in attending interim hearings. We heard the workforce shortage needs, whether that's from retirements, burnout, a growing population. There are many factors that add and contribute to our workforce shortage in the healthcare world. And so this bill is to address that from the interim committee and as well as one of Governor Patrick's main priorities. So members, I would say the 2 key programs previously created to help address this shortage was the Nursing Faculty Loan Repayment Program, again from way back in the 71st legislature, that we are going to fund in Senate Bill 1. Currently it'll be House Bill 1, and then the Nursing Innovation Grant, which I think is extremely important. We've had good input throughout the process. I know that we probably have one little area that we have to fix when we go to the floor with an amendment, but other than that, I think that the bill is in pretty good shape. So with that, members, I'll open myself up to any questions, or we can go to invited testimony. Okay.
Sorry. Chair calls up Colleen Marzilli, Heather D. La Garza, Elizabeth Merwin.
Good morning, Chairwoman and committee members. My name is Colleen Marzelli, and I am testifying on behalf of the Texas Nursing Association in support of this bill. We have a severe nursing shortage in Texas. Supply and demand data from the Texas Center for Nursing Workforce Studies indicates we are over 30,000 nurses short of meeting demand. Notably, that data was gathered before the pandemic, and we expect the pandemic put us in an even worse position. This bill is critical for addressing the nursing shortage. I want to thank the Lieutenant Governor for designating this a priority bill for this session. I also want to thank Chair Kolkhorst for her leadership on this issue. And thank you to the committee for taking the time to hear this bill. This bill is designed to streamline programs with a proven track record of success, and I understand it is being paired with significant appropriations on the budget side. The bill's scholarship program will help us bring in talent from lower income families. The expansion of the faculty loan repayment program to part-time faculty will help us recruit faculty. The extension of the Nursing Innovation Grant Program will help us with simulation and clinical education, and the associated funding will capitalize on these strategic changes to the programs covered in the bill. As a nurse educator, I have sat in countless faculty meetings where we discuss challenges of being a nurse educator. A few themes always emerge. We are passionate about nursing education, and we do not do this for the money. However, nurse educators know that we would make more money in the clinical setting, but our call to teach the next generation of nurses motivates us to walk away from an increased salary. However, inflation is a real thing, and more nurse educators are struggling with the increased cost of basic goods. This bill not only helps faculty members with their student loan repayment, giving them more money to buy basic goods, it also helps ensure that our nursing educators there to teach the next generation of nurses. Additionally, we know that nursing has a faculty shortage and a nursing shortage, and extending this to part-time faculty helps increase the available nurses that can become nursing educators while having the cost of attaining their advanced degree repaid. Also, this legislation helps support the Nursing Innovation Grant Program, and I was able to serve as a PI for one of these grants. This grant provided crucial support for nursing simulation during COVID, and the continued allocation of money towards this grant program will help nursing schools across Texas address the critical challenges of providing high-quality nursing education when clinical sites are becoming increasingly difficult. Thank you, members, and I'm happy to answer any questions you may have.
Members, are there any questions? Thank you. Next.
Good morning, Madam Chair Kolkhorst and members. My name is Heather De La Garza, and I am the Assistant General Counsel for the Texas Hospital Association. I'm proud to testify this morning on behalf of THA and its more than 650 members in support of Senate Bill 25. Hospitals are experiencing significant workforce shortages. These shortages were a problem prior to the pandemic, and the pandemic exacerbated the problem. According to the Texas Center for Nursing Workforce Studies, RN and LVN vacancy rates more than doubled from 2019 to 2022. THA surveyed its members in late 2022 to help quantify workforce challenges. Responding hospitals reported a 16.5% vacancy rate, with responding rural Texas hospitals reporting a 15.2% vacancy rate. Texas hospitals are struggling to keep jobs posted as positions churn and turn over quickly. But even so, responding hospitals reported 90% of vacant full-time hospital positions are posted, while the center estimates it takes 61 days to fill a position. With these persistent vacancies, 64% of our Texas hospitals reported having to reduce services, which impacts access to care. Even as COVID-19 is finally hopefully subsiding, these pre- and post-pandemic related challenges have led to an unsustainable situation that threatens hospitals' ability to care for Texans. We know this problem won't be solved immediately, but the sooner we start investing in implementing solutions, the better. To that end, THA supports SB 25's amendments to the Education Code to provide scholarships for nursing students and allowing nurses acting as part-time faculty members of a nursing degree program to be eligible for loan repayment assistance. We also proudly support extending the overall life of the nurse faculty loan repayment program until 2027. In 2021, Texas nursing schools turned away 15,709 qualified applicants due in part to a shortage of nursing faculty. By expanding eligibility for the program, more nurses will be incentivized to serve as faculty, which we believe will increase the amount of nursing school spots available to those qualified nursing school applicants who want to be nurses. We also want to take a moment to thank the Senate for increasing funding for Article III programs that will grow the healthcare workforce. We have jobs waiting to be filled, and we have people who want to enter the healthcare workforce. Growing the workforce pipeline is a true infrastructure issue for our state. Thank you for the opportunity to testify today, and I'm happy to answer any questions.
Members, any questions? Good. Next.
Good morning. I'm Dr. Elizabeth Merwin. I'm Dean of the College of Nursing and Health Innovation at the University of Texas at Arlington, and I'm on for Senate Bill 25. Good morning, Madam Chair and members of the committee. As a nurse, I am pleased that there has been so much discussion at the state level on how to best advance the next generation of nurses in Texas. UT Arlington is the largest producer of nurses in Texas and one of the highest ranking and largest programs in the country. Last year alone, UTA graduated over 3,000 baccalaureate prepared nurses, more than 1,400 master's prepared, and 105 doctoral graduates. And we're committed to working together to make sure we have the healthcare workforce we need. And this is an important bill and a step forward in addressing our state's nursing shortage, which has been growing for years and was only exacerbated by the pandemic. In 2018, a Texas Center for Nursing Workforce study forecasted the nursing supply and demand to be in deficit of more than 57,000 nurses by 2032. In 2021-22 academic year, there were over 91,000 qualified applicants nationwide to baccalaureate and graduate programs who were not able to be accepted, although they were fully qualified due to a lack of resources. UTA alone turns away roughly 2,000 applicants a year for a pre-licensure program. This is primarily due to a limited availability supply of qualified faculty. It is heartbreaking to talk to students who have worked so hard to achieve the necessary qualifications, but are then not accepted into the program of their choice. The pandemic inspired more qualified applicants to want to join the nursing field, but at the same time, it also significantly increased the need for more nurses.
Thank you. Madam Chair.
I want to highlight, you said UT Arlington, who actually is the largest producer of nurses in the state of Texas, turned down how many applicants?
I think it was a little bit over 1,700, between 1,700 and 1,800, to pre-licensure RN programs. But across the country, there were 91,000 such applicants, which the implication is that with what all the resources it takes, which would be clinical sites, faculty, preceptors, classrooms, that the country has people who want to become RNs, but we have to
open up the pipeline is what I call talk about. Is we have to have the spots for them, the rotations,
Right.
To open up the pipeline to be able to produce them. It's a profession that is such a caring profession, such a giving profession to all of us, in our greatest time of need. The nurse is always there. So I look forward to working with y'all and making this a model bill for the country, and to be able to open up that pipeline, get more nurses out there so that we can meet the needs.
Thank you so much.
Do you have the cost of an RN? Madam, I'm sorry. What's it cost for the 4-year RN program, or however many years? What's it education cost?
I don't have the exact cost. I imagine it's around $30,000.
About 30 grand? Okay.
But it's off the top of my head, and I will get you that information.
Okay. All right. Appreciate it. Members, are any questions for these witnesses? All right. We open that for public. Okay, Chair will now call up for public testimony on Senate Bill 25. Elizabeth Merwin, Diane Santa Maria, and Elise Meyer. Diane Santa Maria, Elise Meyer. These are the only two I'm showing that wish to testify publicly. If there's some others that are listed that would wish to testify publicly that have not registered to do so, please do so now. State your name and who you're with in 2 minutes, please, on position on the bill.
I'm on the bill. My name is Diane Santa Maria. I'm Dean and Professor at the University of Texas Health Science Center in Houston, Cizik School of Nursing. And I don't want to repeat everything that was already stated, as you have some really nice facts there, but when we look at the last 50 years of the graduates we've had over 15,000 nursing graduates that have come from our school. We have exceptional nurses. These are nurses who are by the bedside, who are leading our hospital systems. And yet, even during the pandemic, we've seen a decline in nursing enrollment and nursing applications. And part of that is driven by what we saw during the pandemic. Nurses were impacted in ways that other healthcare professionals were not. And students and prospective students were taking note of that and were perhaps changing the way that they were going to think about whether nursing was going to be their career. So unless we do something dramatic, which is what this bill supports, we're not going to have the nursing workforce we need tomorrow, let alone in what we need in 10 years. This is especially important and needed in rural and underserved communities, for primary care settings, and for the unmet psychiatric and mental health care needs of our state. Nurses are needed to be incentivized to be able to go back to school, to be able to come into the nursing profession. In order to do that, they need to have substantial amounts of scholarships. There are other applications and other ways that they can put their career. They can go into computer science. It may seem to the public that that's a safer career than nursing, especially as we watched what was happening to nursing and in health hospital systems across the nation during the pandemic. So we need to be able to incentivize those young people to come back to our profession. Additionally, we need to be able to incentivize nurses to come back to school to get their DNP and their PhD, so that we have the nurse faculty we need in the future in order to be able to educate those students. This is partly what's driving some of the nursing workforce shortage, is that we don't have the faculty that we need in order to be able to educate these students. I was one of the recipients of the nursing education nurse faculty loan repayment program.
Thank you.
And I can't thank you enough for that.
So you're on the bill, though. You're not for the bill. You're on the
I'm on the bill.
And you're not for the bill because it doesn't do...
Because I work for University of Texas Science Center.
Okay. Yeah, that's probably, I didn't connect there. You're not an agency. So. Yes.
If you didn't work for the University of Texas, would you be for this bill?
I would be for this bill. As a recipient of some of the things that this bill supports, I would be for it.
I appreciate it.
I have another question, Mr. Chairman.
Madam Chair.
You talked about the support systems and different things. Do you think this bill accomplishes one of the key elements, which is faculty? You can't produce more nurses if you don't have faculty.
I think by expanding this to the ability to fund part-time faculty, it allows for nursing faculty to also be able to be care providers. They can provide direct patient care as part of what they do in their career, as well as educate students. So it absolutely does open that up. And the addition of scholarships is something that we really need to consider here in Texas. There is a true campaign from out-of-state schools coming here and taking our Texas students, offering them scholarships that we're not able to offer here at the state.
And that's very key is the legislature, and again, as I said, I don't know, we almost have every senator as a primary author or a co-author, is the seriousness of this. And the lieutenant governor, of course, in his inaugural speech, laid out, this is a top priority of what we need to do. And so keeping our Texans, we are a wonderful state full of resources, including our human resources. And so, we're very focused on producing and keeping them here and giving back to our communities.
Thank you. Thank you. Next, Elise.
Good morning, Chairwoman Cold-Korst and members of the committee. My name is Elise Meyer, VP of Advocacy with Leading Age Texas, in full support of SB 25. We advocate for nonprofit aging services providers, including nursing homes. The overall impact of the statewide nursing shortage is well known. However, certain healthcare settings, specifically nursing homes, continue to be disproportionately impacted by COVID. I provided two resources. One, just to illustrate the raw numbers to show you the steady decline in clinical employment. Within nursing facilities, we've seen an 18% decrease in RNs, 14% drop in LVNs, and 23% drop in CNAs employed by Texas nursing homes. And then the 2022 long-term care staffing study provides a window into nursing home staffing. It highlights key measures like vacancy rates, use of contract staffing, and the impact of COVID-19. Nursing facilities reported the highest vacancy rates for RNs in the state across all healthcare settings at 27.3%. In addition to rebuilding the Texas nursing workforce, student loan repayment programs have proven to be impactful in recruiting and retaining clinical professionals into specific healthcare settings. SB 25 allows the Higher Ed Coordinating Board to establish the categories of persons eligible to receive scholarships and loan repayments, including whether that person is practicing in a geographical area, practice setting, or an area of practice with an acute nursing shortage like nursing homes are experiencing. We'd encourage the committee and the Senate to continue discussions and provide some direction to the Higher Ed Coordinating Board by identifying and prioritizing practice settings experiencing the worst shortages. We'd ask that you consider dedicating a modest amount of funding to the student loan repayment program to create a valuable incentive so nursing homes can recruit, retain, and ultimately improve care for Texas nursing homes.
Is there any questions? Thank you for being here today. Appreciate it. That is all I show wishing to testify publicly. Is there anybody else wishing to testify publicly on, for, or against Senate Bill 25? If not, see none, public testimony is closed. The bill will be left pending. Chair lays out Senate Bill 26 and recognizes its author, Senator Cold-Korst, to explain the bill.
Thank you, Mr. Chairman. Members, Texas has made historic investments in mental health over the last several sessions. In the 87th legislative session alone, the state invested more than $8 billion across all agencies for mental health services. Mental health services in Texas are delivered mainly through 39 community-based behavioral health services organizations and 10 state-operated hospitals that work together to create a network of state-funded, locally delivered mental, behavioral, and psychiatric care. Currently, Senate Bill 1 has more than $700 million allotted to increase community-based services and interventions, and Senate Bill 30 contains more than $2.3 billion, 2.321 to be exact, in support for expanding mental health facilities in state hospitals. Despite these investments, we've all heard from our local community leaders that Texas has an increasing number of individuals with mental health needs cycling in and out of our hospitals, community programs, homelessness, and jails. Waitlists for mental health services and community programs in the state hospital system have grown. As Senator Perry knows, and Senator Hall, working on Article 2, we've done a pretty deep dive. And for example, nearly 2,500 Texans await a state hospital placement to receive treatment. Of those, all but 73 on our last report are waiting for competency restoration with forensic beds, and that includes maximum security. So, members, the state hospital system has some very dedicated staff, and we know that we have more than 600 beds offline due to a staffing, as we heard in the last bill, a staffing crisis. But Senate Bill 26 looks to expand local mental health access through innovation and accountability. Additionally, there is a need for increasing access to services targeted at youth, particularly those at risk for entering the juvenile justice system and child welfare systems, and to address the Texans who remain in state hospitals for more than a year. Senate Bill 26 seeks to address these issues, especially for children and adolescents, through the creation of an innovation grant program that would provide grants to a variety of providers in different settings, including hospitals, LMHAs, hospital districts, nonprofits, that can address the factors that can lead to a youth to a crisis. The bill also directs structured methodology for transitioning patients out of state hospitals to reduce the readmission of individuals and to ensure they have proper supports for the patient and to ensure that that patient can return to the community. It also increases transparency and accountability for Texas community-based mental and behavioral health systems by requiring them to submit to regular performance audits and to post monthly data on their services outcomes. And finally, it directs HHSC to consider exploring funding options for nursing homes that could provide a long-term placement for some individuals with high behavioral health acuity. We have a number of individuals that are in our state hospitals right now that we call 365ers that are there day after day, year after year. And there might be a more proper setting for them rather than being in one of our state hospitals. And so, members, Senate Bill 26 will have some cost-related and does have a little bit of a fiscal note for the requirement that the audit section of the bill. However, the rest of the bill is assumed in the base budget bill, Senate Bill 1, which will become HB 1, and that's in Rider 40. And of course, I've mentioned the Senate Bill 30 that makes up substantial investment. We will continue to work with OIG and HHSC to reduce the fiscal impacts. But I want to say, too, that as we look out and the incentive payment and creating the new program, also the auditing of 39 LMHAs, which I don't think has been done, and we might hear some testimony and pushback on that. There are many state agencies. I've considered putting them under sunset, because, again, 39, there's a lot out there. There's a lot going on. And after this session, we have hit, under Governor Patrick and our work on the budget, we've hit historic highs in these fundings, but we're really going to hit another historic high. And what gets measured gets fixed. And I think that that's super important. I know that there's local boards, but through the years we've tried to add a sheriff to the local board to try to get the jail competency and also the forensic bed issues addressed. And so this is another effort to make sure that the billions of dollars now that we're pushing out are accounted for with the taxpayers, but most importantly, getting to the services that people need and that we have funded. So with that, members, take any questions. I know we have invited testimony.
Yeah, I'd just say, Madam Chair, I appreciate the holistic approach that you've looked at this with the monies that were available and how we best serve very underserved geographical regions through this process, and addressing some of the statistics of where those beds are needed and how they relate. I also do agree that our LMHAs, we've been in existence a while, and I consistently have had from sheriffs specifically when they're dropping those clients, I guess, off, they're staying an inordinate amount of time. So I'm not sure that we have bad actors. I'm just not sure that we're not clear enough in our expectations. So I think you've went a long way in your bill to do that, and I appreciate the reporting. I think we need to have some accountability built into that. So any other questions? All right, Chair calls up for invited witnesses, Curtis Young and Andy Keller. State your name and who you're with.
Hi, good morning, Chair and Committee of Health and Human Services. My name is Curtis Young. I am Parkland Health's Operations Administrator for Behavioral Health Services, and I am testifying on behalf of the hospital system. First, I want to acknowledge the increases in funding that you mentioned, and would like to thank you for the improved delivery of mental health services in the state of Texas. There are a number of programs at Parkland that I wanted to bring up today that we believe could be replicated in other communities using grant funding under this bill. First, HHSC could model their behavioral health QIPP project after our Cardinal Wing at Lake West Nursing Facility. Parkland recently opened this wing, and basically it specifically accepts patients who need a nursing home for their medical needs, but also have behavioral health needs or aggressive behaviors, things like neurocognitive disorders, dementia, things like that. So this frees up our bed at the acute care hospital, but also fills the need of the behavioral health community. Another example is our Right Care program. This is a multidisciplinary response team that responds to mental health 911 calls. It consists of one Parkland psychiatric social worker, one Dallas police officer, and one paramedic responding as a team. This is a best practice model and shows decreased ER usage, decreased incarceration, and improved connection to mental health. I'm happy to discuss any outcomes after my testimony. And then finally, I'd like to mention our middle levels of care, intensive outpatient programming and partial hospitalization programs. They're not currently funded by the state for unfunded patients. These programs free up our inpatient psychiatric beds by stepping patients down from inpatient into an IOP or PHP faster than if the patient were to discharge directly to outpatient care. Similarly, patients can step up from outpatient or an ER to an IOP or PHP and avoid the use of that inpatient bed altogether. We all know that those are very precious resources within the system of mental health. So with that, I'm happy to answer any questions that the committee may have. Thank you for the opportunity to testify.
Madam Chair.
Thank you for being here today and testifying. I know a little bit about some of your programs, and y'all are really, doing a good job in looking at what the needs for the community are and then stepping up to meet them. So when did your nursing home open up and how many beds?
Thank you, Madam Chair. It was within the last year that we've opened that up, and I'm not exactly sure how many beds it is. I'm going to say it's 8 to 10. And
then average length of stay, would you know?
I don't.
Okay, you can get that to our office. And
I can, yeah.
The Right Care team. Mm-hmm. So with that, you described that it's kind of a team. How do y'all identify the individuals that you need to, and then how do you deliver that care to them?
Good question, thank you. So it's all through the 911 system. Somebody calls into 911 and they identify that as a mental health emergency, and then they dispatch that specific team. So those teams are in one vehicle, they have the police system within the vehicle, and they are dispatched to that call.
So it is triggered by a 911.
That's correct.
And then the last program that you, right after Right Care Team, what did you mention?
Those middle levels of care, intensive outpatient programming and partial hospitalization programs.
Mm-hmm. And how many people do y'all serve with that?
We don't currently have a program. We're currently developing this in partnership with some of our outpatient providers, but do think that this program could qualify under this bill. We're hoping to serve 100 patients, adult patients per year through the program, and then 100 adolescents and children through a separate program.
And so when you look at Parkland and what you're doing, which of course y'all are a hospital district, but how do you coordinate with your LMHA?
We actually partner very closely with our LMHA. We have our extended observation unit is a partnership where they actually have their staff on site within our program. We partner with them for the Right Care Team because they have clinicians in the 911 call center, as well as our inpatient and getting our patients transferred out. Parkland actually has a fairly small inpatient psychiatric unit that stays full 100% of the time. So we count on them to help us move our patients to other inpatient psychiatric facilities.
How do you see the new UT Southwestern mental health hospital coming online, and what role will it play?
We're really excited about that 300-bed facility that's being built across the street. We do think that will have an impact on our ability to move patients out of our ER system and hopefully decrease the acuity within our own inpatient unit, because right now we don't have access to state hospital beds very much at all right now.
Right, so y'all don't refer to Terrell at all?
We will refer, but the ability to actually get a patient transferred has decreased dramatically over the last 3 years. I think we sent 6 patients there last year.
Why is that?
My understanding is that it is being used primarily for forensic beds, but there are also a number of beds offline. Competency restoration is what I meant by forensic. But.
So the challenge of when we look at our wait list in Texas, like it's 2,500 and change, waiting for a state mental health bed. Of those, all but 73 are forensic. MSU, maximum security unit, over 1,000. So when you look at what y'all are doing and innovating on the civil side, y'all really rarely touch the forensic side. Am I right on that?
That's correct.
So what I've found is that, and it's not all LMHAs, but when we kind of talk about this forensic bed need, again, we're going to do some jail competency restoration. Some jails are set up for that, some are not. There is obviously in the free world argument, is that the best setting to restore mental competency? You know, I think that we have to know there is some really good things going on outside of the state government, meeting the needs, right? But then there is this whole issue that we hear, when we hear from county judges and when we hear from sheriffs, I mean, the county jail should not be a mental hospital, other than when we have a great setting that we can do jail, jail competency. So what's your thoughts on that, the balance of civil versus forensic?
I mean, yeah, there has to be a balance. I just don't think we have all the resources that we need at this point. And it is clogging up the system, honestly. So it is impacting our ability to treat folks appropriately within the healthcare system, because we're holding on to patients for so much longer than we would. Our length of stay is longer, so that backs up into our ER in terms of how we can transfer patients through the system. So there needs to be a better balance, I think, yeah.
Would you get to me average stay and how many beds y'all have?
We have 28 beds at Parkland. 28? Yeah, out of a 950-bed facility.
And average stay, do you know?
Last month, it was about 18 days.
Okay.
18 to 20 days. And that's the average is typically, I think, between 7 to 10.
So last month, 18 to 20. And when you discharge, let's talk about that one more second. Where do you discharge to?
Well, oftentimes we're discharging to the community. So it's oftentimes to outpatient care, to families, to their own home, boarding homes, even homeless shelters sometimes. So, but it is making a very strong connection to outpatient care from our inpatient units. So if we're seeing them a lot, we're going to connect them to ACT services, which is a very high level of outpatient wraparound services. If not, we're going to, every patient that leaves our inpatient unit has an appointment in hand and medications in hand when they leave. But there's other opportunities there, I think, as well.
Is there anyone that is necessarily, or any organization that is necessarily in charge of, for outpatient, who's responsible for kind of that outpatient and follow-up? Or is it, the responsibility of the individual or the responsibility of a loved one?
It's the hospital's responsibility to make that appointment and make sure that they understand that they have that resource for themselves. In terms of if they make that appointment or not, that's kind of on the patient and the family. If we are concerned about them, that if they won't make it, we can really try and partner with that outpatient provider to actually come to the hospital and meet with the patient before they discharge to really try and build rapport there. So it's a team effort.
Thank you. Appreciate it.
You're welcome. Thank you for the opportunity.
Mr. Keller.
Good morning, Chair Kolkhorst, committee members. Thank you for the chance to be here. My name is Dr. Andy Keller. I'm the President and Chief Executive Officer of the Meadows Mental Health Policy Institute. And Chair Kolkhorst, just at the beginning, I really want to, I'm testifying in favor of this bill for Senate Bill 26. I just want to express my appreciation for how this bill does complement the tremendous increase in resources that are going to address, I think, many of the issues that Curtis just went over. But they're only going to address the priority issues if we have the kind of accountability and the kind of focus that this bill lays out. So I really appreciate that. I want to talk about two components of the bill in particular that we believe are critical from our standpoint at the Institute. One is this issue of helping people who are long-term residents at the state hospital facilities who've been there for over a year. Most of these people do not need inpatient psychiatric care. The reality is these folks are at a place where all of us will get to at one point in our life, if we live long enough, which is they're not able to care for themselves independently in the community. And there's generally two groups that I think this bill will address. One of the groups are the group who need this level of nursing care. So it's a nursing facility care. Their functioning is at a level where that's what is to be required. And you can't just have a regular nursing facility do that. There's going to have to be a specialized program, specialized funding. So I think this bill creates that opportunity. The other group are folks who don't need that level of care, but do need assistance in the community. And by being able to create an infrastructure where community providers work more closely with the hospital around discharge, as laid out in this bill, to be important. I do think those community providers are going to need better resources available under the HCBS AMH program, the 1915I state plan program. Right now, that was set up with so many bureaucratic requirements that were required under the Obama administration. They really need to be redone. And I think that will complement what's in this bill. It's not currently in this bill, but I think if they have those tools, this bill will, I think, be even more successful. The other thing we want to just call out, just for attention, are the innovation grants, and particularly the way in which you are bringing and harnessing the entire talent pool in the community by including all the different categories of potential folks to help to make sure that we bring innovation to the youth of Texas. So I just want to appreciate this bill, and I'm happy to answer any questions.
Madam Chair.
Yeah, just thank you for testifying. I know y'all have done a lot of work through the years, Dr. Keller, and we'll continue to work on this bill. I'm going to leave it pending today because there's a couple of things that the more we get into it, the better the bill gets. And so I appreciate y'all's feedback. I want to say again, Governor Patrick and the base bill, along with Senator Huffman, very large amounts of money. In my time of serving in the legislature, we've never seen anything like it. And so we're hoping to be able to, start by addressing the acute needs. We know that there, is a wait list. We have to attack that. But then, again, a lot of things happening out there coming online, the UT Southwestern Hospital, for the forensic side, RUSC is coming online this summer. We do have in our communities a lot of innovation going on and taking best practices and applying that throughout. As you know, not everybody needs a mental health bed. They need some skills, coping skills, and occasionally, just a respite. So I look forward to working with y'all and taking these precious dollars and making sure that, again, sometimes it seems like we build bigger government and a lot of services instead of getting it down to the people, and that's one of the things we got to push it out to the people. So we appreciate your feedback. Give it to us. Let us know.
Well, thank you, Chair Kolkhorst, and I couldn't agree more. We're here to help. This is our job. Happy to research anything, help bring ideas together on that. And and I do think we also really appreciate the Lieutenant Governor working with you to make this a priority bill. It's just, I think, focusing on these priority needs. These are the primary points of tension that I think you've identified in this bill, and I think by bringing the people to the table you have through this, I think that's the path we need.
I think, too, there was some testimony last week where someone talked about their brother being in a mental health hospital who has been there for over a year, maybe many years, and the setting that person is in. And I'm really excited about the part of where we could give a better home, a better place to live than when your visitor comes being locked behind 3 doors. That's something that excites me about the opportunity. I think it's going to take a while to develop. As you say, it's, kind of specialized nursing facilities, but I think we can get there. And Parkland is leading the way on that. So thank y'all very much.
I do have Mr. Young. First of all, Parkland does have a big footprint and something we can learn from. All my experiences with people who have experienced your services is good. You make a comment, and I've said it before, you can lead a horse to water, but you can't make them drink. So you said it, we can set all the appointments in the world, but if they're not participating. So in rural Texas, specifically some of the healthcare delivery models that Tech is kind of pioneering, they're physically going out. So the question I have for you is someone that's in this crisis mode or gets this particular treatment and goes home, is it something that requires a very specific clinical setting? I don't know if meds are involved, those kind of things, but, we have wellness checks. If you have a concern about someone, you can call and cops will come by and knock on the door and see if everything's on. Is there some aspect of that for those that you know for a fact are going to be back on the treadmill? They're just in the hamster wheel circle. Is there some aspect of where we need to look at maybe having someone go out and physically follow up in that setting? Is it possible from a clinical perspective is the question I have, or is it just require such a unique subset, skill set, and other aspects that you wouldn't be able to send someone out to meet that need?
Thank you, Senator. There are absolutely programs that do that. The program that I referenced called ACT it does exactly that. They kind of call it a hospital at home kind of thing. So they have so many hours where they can actually go out to the home. They can bring their medications with them, make sure the patient's taking them, check in with them.
As much as I hate to do that, from a policy and just general perspective, at some point somebody's got to kind of sort of take responsibility, and these people that can do outpatient should be in that mindset, I would think. But do you have an idea of how many people are no-shows? Because that's a really inefficient, my Medicaid providers will say, we don't mind doing Medicaid, we mind setting Medicaid appointments that they never show up for. And I've wasted all that opportunity cost. So do you have any statistics that would say how many times you set outpatient appointments or how long someone participates? It's probably a 12-month program or longer or whatever, and they do it for 2 months and then they're out. I mean, do you have any kind of data that would let us know what that looks like?
Well, so for some folks, serious mental illness is a lifelong issue.
Right.
And so one of the things that we're doing is we've actually brought in some of our outpatient providers into our ER. We call them liaisons. So we have somebody from MetroCare Services sitting in our ER. They can meet with the patient there. And now we're starting to collect data. We've just started this about a year ago. We're starting to collect data in partnership with MetroCare to see how many of those appointments that liaison is making for our ER folks, how many of them are making it to that appointment within 7 days, 15 days, 30 days. And then how can we get that percentage higher than it is? Right now, for the 30-day appointments, this is just from the ER. This isn't all around, but just from the ER, we're sitting at about 50% of the people make that appointment.
50?
That's correct.
All right. Thank you for what you do. Members, are there any other questions for these invited witnesses? Thank you all for being here. Appreciate your input. Chair opens up public testimony. Greg Hunch, Lee Johnson, Audrey Neal O'Neill, and Eddie Paradas. State your name, who you're with, and position on the bill in 2 minutes.
Good morning. My name is Greg Hanch. I serve as Executive Director of NAMI Texas, which is the Texas affiliate of the National Alliance on Mental Illness. My testimony is in support of SB 26. Thank you for this excellent bill. We represent end users of services and family members. We do hear some common themes from them. There have been noticeable improvements in the availability and quality of mental health services. There was a time where LMHAs were viewed fairly unfavorably by NAMI. And that was because people were having a hard time getting into services, and once they got in, they felt the care wasn't very good. But the legislature has shown a remarkable commitment to improving services, and we appreciate that. We do hear, still to this day, a fair amount of negative feedback about quality and access. We hear from people who are on a wait list for services, or they say their services are meager, or that their provider was disengaged. To some extent, we believe that that negative feedback is because of the long-standing reputation and stigma that LMHAs have carried with them. But much of what we hear is driven by deeply personal and intimate engagement with the system. And when people tell us that their services are delayed or poor, we're inclined to believe them. We believe that this bill goes a long way to improving transparency in LMHA outcomes. One of our concerns has been that people are in a lower level of care than the one that they're clinically recommended for. And we're very encouraged by this bill requiring data reporting on that. We encourage you to drill down a little further and put in this bill the reason that people are in a lower level of care. We need to know, is it because there aren't enough resources? Is it because people are refusing to engage in that higher level of care, the one that they truly need? It would be very helpful to have that data so that local interventions can be designed based off of that. And finally, I just want to say the other components of the bill are things that we all strongly support: the improvements in the discharge planning process, the innovation grant program to drive early mental health interventions, which is a smart approach to facilitating long-term recovery and reducing preventable admissions. We also support the long-term care for patients who are stuck in state hospitals and the other accountability measures for LMHAs. Thank you,
Greg. Madam Chair.
Greg, thank you for many years of testifying, and continuing to work on this is it's ever evolving, and one size does not fit all, as we know. But I appreciate your feedback and the transparency part of this bill. I too receive feedback that services weren't rendered, they weren't timely. We've got to figure out why that is, and if the system is working. And we do that with state agencies all the time, and trying to reinvent them, make them better, be more responsive to the citizens. My gosh, with DFPS, we're pushing out community-based care and different kind of model to meet the needs of our communities to be more responsive. So as we work through the process, I'd like to continue to receive your feedback and how we can tweak this bill and make it the best that we possibly can, along with the funding. Oftentimes here in the legislature, we think we give these mental health dollars out and we say, well, that's the only mental health being delivered. There's a whole world outside of this that I've had feedback from that are going on that you don't have to go through a local mental health authority to receive. So, you know, again, taking our precious dollars, trying to get them to those that are in greatest need, but working with our local communities to meet the needs of those communities is super important.
I think it's wonderful that this bill, the Innovation Grant Program, includes some of those external community partners like nonprofit organizations, non-LMHAs. A lot of the time, those types of service providers can make a true difference in improving and bolstering the continuum of care. And then the final point, just to reiterate something I'd mentioned, was I think we can drill down a little further on the data collection piece. I think that the elements that are required in there to add to the data reporting system that currently exists are good, and that's all that data would be helpful, but particularly focusing on the reason that people are in a lower level of care than the one that they're clinically recommended for, I think will go a long way in ensuring that we know are people in the right level of care. Not only are they getting services, but are they getting the right services? I think that's a really important thing that needs to be looked at.
And combined with the workforce, do we have the workforce out there to have the delivery model to help people? And so give us your feedback. We're going to, keep working on this and have it, as a framework. And again, I've spent the better part of the last 6 weeks on the budget. My staff is so happy that Article 2 is almost done. But that, again, the money has to be there to drive the policy. So thank you.
Appreciate it.
Lee?
Thank you, Madam Chair. Members, my name is Lee Johnson. I serve as CEO for the Texas Council, the state association that represents the local mental health and intellectual disability authorities. I'm testifying for Senate Bill 26 today. Thank you to you, Madam Chair, to Chair Huffman, and to the Lieutenant Governor for including significant mental health funding in the state budget. These additional investments create opportunities to further strengthen the mental health system in our state. My testimony in support of Senate Bill 26 focuses on sections 2, 3, and 5. In section 2, on one hand, you could look at the extent to which oversight exists today and think that would be sufficient. Our system today has performance contract outcome requirements reviewed by HHSC regularly, quality management performance reviews, CCBHC certification and recertification, substance use licensure requirements, and LBB performance measures to ensure state resources are used as intended. On the other hand, we understand the need for heightened oversight when substantial investments are being made, and we have every confidence in the Office of Inspector General. We support the enhanced discharge planning provisions in Section 3 because great care must be taken when individuals who have been hospitalized for more than 365 days are transitioned to community. In FY22, our system expended $22.4 million on continuity of care for adults, translating to more than 162,000 service events. For children, the system expended $5.9 million in more than 38,000 events. One part of the bill to consider is Section D. The language in the introduced bill directs local authorities to arrange services for people who may not meet eligibility for state-funded services. Reinstating the previous provision would clarify this. And finally, provisions in Section 5 strengthen public access to service and outcome data. We require to report a tremendous amount of data to HHSC already. For this new public reporting system to be reliable, clear definitions and reporting parameters must be established, and the state's electronic health system should be resourced to support automated data submission, capture, and reporting. We stand ready to participate in the development of protocols necessary to make this happen. Thank you so much for the opportunity to testify. Glad to answer any questions.
Thanks, Lee. Any questions, members? All right, Eddie, you're up next. I have 3 left: John Nix, Lynn Rutland, and Melissa Shearer. If that's any more wish to testify publicly, please register now. Eddie, you're up.
My name is Eddie Paredes, and I am on the bill with recommendations. Thank you, Chair Kolkhorst and members, for the opportunity to offer testimony. I am a Texas-based nursing home provider and the point of contact for the Independent Coalition of Nursing Home Providers, whose members operate over 600 skilled nursing homes in Texas. Senate Bill 26 has many positive aspects, but does pose a concern as it relates specifically to nursing homes, which we believe are yet workable. The chief concern is the use of the QIP Quality Initiative to fund the nursing home piece of the program. It is important to recall that QIP is funded without any state general revenue and uses only IGTs provided by local non-state government organizations. These IGTs are voluntary. QIP has proven to be the primary tool that the state uses to improve the quality of nursing home care, tied to us earning quality metrics, but QIP also has an HHSC limited funding cap. In order to accommodate Senate Bill 26, there would need to be a significant increase in the current QIP allocation. In fact, just to maintain the current program level, QIP requires an increase in the current cap amount to account for the large participation growth we've experienced over the last 4 years and not reduce any benefit reductions. Bottom line is, the QIP program is an incredibly important quality driver for the state, and anything that impacts it must be thought through in detail to avoid unintended negative consequences. Here's our recommendations. We have 2 alternative approaches. First, prior to implementation, require HHSC to complete a study and report to the 89th legislature. The study would focus on program details and the funding mechanism that would be required to support it, including conditions needed for ultimate CMS approval. As currently contemplated, CMS approval is questionable. Thank you, and I can answer any questions.
Madam Chair.
Go ahead and finish that point, if you would.
As currently contemplated, CMS approval is questionable. Second, a minimum, Senate Bill 26 should require HHS to increase the QIP funds to accommodate the metrics associated with creating an opt-in mental health specialty population program. This requires an increase to QIP of at least $400 million to effectively fund the proposed initiative. Basically, in a nutshell, we can do it. We need more training, education, environmental support, and to do that, we can't pull it out of QIP because it will reduce the other current QIP metrics, so it has to be an additional funding.
Madam Chair.
So, Eddie, I think that the bill is pretty clear on that. It's permissive. So you certainly, make some points. And I think what we need to do is to look at every avenue possible. I think it was in December I asked y'all to come up with a plan, and y'all didn't. So this train is rolling. So you better get on the train because it's rolling. We're not going to lock away people in mental hospitals for 365 days. You, in testimony in Senate Finance, said y'all have a 40% vacancy in nursing facilities across this great state. So we have 40% of the beds sitting there empty. There is a need to be able to move people out of the highest acute setting into a setting that is more proper. So I look forward to working with you and your industry, which we have done for many years. But this train is rolling. And you were asked to give input in December. I didn't hear anything. So hence, Senate Bill 26 is written the way that it is. So I look forward to working with y'all, but this train is rolling.
Senator
We're going
Colquhoun,
to do something.
We apologize. We did respond to your office with a
It
concept
wasn't
paper.
very detailed, and it really did not, a study is not going to cut it. So having said that, we're going to try to, when you look at where the issues are with precious beds out there, and I get your workforce issue. That's why Senate Bill 25 is being laid out today, right in conjunction with Senate Bill 26. We have a crisis on our hands. Your industry has a crisis, and that crisis is 40% vacancy. So let's work together to try to come up with great solutions. I'm not saying that we need someone who has some challenges with their mental aptitude to be right next door to a stroke victim like my mother was. I'm not saying that. We have a way to move forward. Y'all have facilities. We want to work with you. If you don't want to work with us, we're going to move on. But there is a way to do better.
If I can be very clear, the nursing home industry wants to work with you. We actually have 69% occupancy, but the point is well taken. We have 30% empty beds. Totally agree with you. We can help, we can provide those services, but to safely do it, it is a different population, and to mix those populations is a bunch of concerns.
We're not going to mix them.
So we're there
we're going to find a way
to make dedicated buildings just for this specialty population. We can figure that out. We just need the funding, and we're there to do it with you.
Eddie, Parkland did it. Parkland Hospital is doing it.
Parkland has a 10-bed unit, and they supplement that 10-bed unit with more funds.
I know,
It's
we
10
know
beds,
that.
but they pay that nursing home more than the Medicaid rate to be able to care for those patients.
Yeah, I'm not saying this is an inexpensive proposition, and I can give you bed rates from, what we're doing with contracted beds, which LMHAs do, and I know Sonia Gaines, we've gone through over and over and over, what are we paying here? And it's interesting, throughout the state of Texas, and I've got to brag on some parts of our state that are meeting the needs of what we have out there. Hospital has taken some beds and converted them and given us great rates that I'm so proud of, and the different ingenuity. What we're trying to do through Senate Bill 25 is designed to say we have a workforce shortage. It's not just in mental health, it's in our hospitals and our nursing facilities, but Senate Bill 26, along with Senate Bill 1, which will become HB 1, is a major effort to say we're going to invest in this population. We know before COVID we had a mental crisis, but post-COVID, put your seatbelt on. And so, I appreciate Meadows and their handout. They were talking about, by the age of 14, 75% of those that are going to present with mental illnesses have presented. So I'm really excited. I just told Maureen that Senate Bill 26 is my favorite bill of the session, and I filed a bunch of them. And so I really look forward to working with y'all. I mean, Senator Perry, I know you and I have had discussions, Senator Hall, our work with what we're trying to do with Terrell and different things. I mean, we are focused this legislative session, and we've put a lot of money into mental health. As NAMI has testified, sometimes those results aren't great. And so we've got to keep working at it. I look forward to working with the industry, and we'll take your feedback.
We can be part of the solution with the funding.
I just suggest States Board of Living Centers, same conversation you just have.
Amen.
There's 10,000 beds there.
We're going to vote on a bill today that allows the mother from San Antonio who drove up here on her own. I don't know who that lady was. She talked about her son whose IQ is 49. She had never been offered a state-supported living center. And I just got to tell you, Senator Perry, that testimony, I was like, I don't even know who she was. She came up on her own to say, we have a problem, we need access, we're going to do better, and we're going to break down the barriers. And everyone doesn't need to be so scared of the cheese moving. We're moving the cheese to serve Texas. It's just not, it shouldn't be that scary. But I know everybody has their fiefdoms, but I appreciate the nonprofits coming forward and saying, oh, we could do better. So we're going to do it. Thank you.
Any other questions, members? Thank you guys for participating. I hope you heard it loud and clear. There's no excuse to have an IQ of 49 declined at a state-supported living center.
I know.
John Nix, Lynn Rutland, and Melissa Shearer. And we do have a resource witness from the Office of Attorney General if anybody had any questions for the department. John Nix, Lynn Rutland, and Melissa Shearer. This is the only three I show remaining that wanted to testify publicly. If you do, now is the time to do it. If you're not registered, then we will assume you did not want to do it publicly. Start there with 2 minutes, your name, position on the bill, sir. There in the middle.
Okay. Howdy, Senator Colhurst. My name is John Nix, and I'm an individual with a mental illness myself. I'm not with any organization or any lobbyist or anything like that. I'm the one that suffers with mental illness. I have severe depression and a little bit of PTSD all the way. And of course, on the IDD side, I have autism as well, high functioning autism. And there's some things right now with what's going on with mental health that needs some major changes. There are people like myself that can't get care at their local behavioral health authority right now, like whatever reason. For some people, like if they don't feel safe, like if their HIPAA is violated, or they've had problems with the staff, or they've been discharged from care when they needed the care for whatever reason. So with all the funding that you're putting into mental health, it's going to hurt not do anything for people like myself. My idea is to create an amendment to this that would allow people to follow the money to go to another county's behavioral health care system. Like if you're in Montgomery County, you'd be able to go to like Brazos County with the MHMRA of Brazos Valley, or say even here with Round Rock being able to come down here to Integra Care to get care that you would feel safe in an area that you would feel safer with. I'm on the Medicaid buy-in program, with the Medicaid with this Medicaid Start Plus, and with how it is now, I can easily live in Montgomery County and have a doctor in Bryan College Station right now as much as like a Bryan College Station individual could have a doctor here in Travis County, but like a primary care specialist. But you can't do anything with mental health. You're stuck going to a behavioral health authority that you may not even feel comfortable or not even allowed to have. So that's my big concern with that, and I know I'm about to have a time. Does anyone have any questions? And I want to also thanks so much for having me coming out to having this meeting today, and have a great day. And gig 'em, and God bless Texas.
John, thank you for being here. Is there any questions for John, members? No, appreciate you participating for sure.
Mr. Chairman.
Madam Chair.
John, did your comments, you wrote that yourself?
Yes, I wrote it myself last night. I have a duplex printer myself. I typed it up over my feelings of what I experienced with. I could be an expert testimony about the problems with Medicaid and with the problems with the Medicaid, including to where they don't even follow the state law in a part of it, and mental health of what I experienced as an individual.
Yep. Thank you, John.
And of course, I've spoken to Cecil Bell about this many, many times in your office, many times.
Oh yes, John.
Yes, it's part of it. I'm proud to have you as my senator.
Thank you. We appreciate you coming all the way to Austin today to testify and to.
No problem. I had to deal with a lot of my PTSD flashbacks of an accident coming all the way here.
Thank you. Thank you, John.
Lynn?
Yes. Good morning, Senator Kolkhorst, the members. My name is Lynn Rutland. I'm the CEO at the Andrews Center, the local mental health authority for 5 counties in East Texas, and so I'm here to testify on what I now know to be Senator Kolkhorst's favorite bill of the session. So I'm right on track. Here we go. Our system of care, the local mental health authorities, embrace the public trust that I think we should all uphold. As Rob Janelle, a dear friend of mine, taught me years ago, Rutland, the money we entrust to you is not yours. Never forget it. So as we contemplate the oversight provisions in Senate Bill 26, please know that we understand and embrace local accountability and transparency. With the substantial investments that you're considering for new mental health programs in the budget this session, if those are realized, then where those dollars go, how they are spent, and are the lives of Texans with treatable mental illness actually better? Those are the right questions to pursue both now and into the future. In my 50 years of public service, 20 years as a state employee at the San Angelo State Supported Living Center, 15 years as the CEO in San Angelo at the local mental health authority, and 15 years as a minister of the gospel in southern Colorado on the banks of the Conejos, please know that I am no stranger to audits and oversight. I came out of retirement in June of 22 to accept the CEO position at the Andrews Center. So in 9 months, we have had 9 state audits at our community center already, so that comes to 1 per month. Not even when I was on the local school board were our audits happening so frequently, nor our sponsoring agencies, cities, or counties when I visit with them. Nowhere is a unit of local government more inspected and more transparent. Today I have a team that have to deal with internal audits all the time. You'll be glad to know that our audit filings are already published. This month, we have 2 such audit results in our board packet. Taxpayers and our communities will have the opportunity to analyze our performance locally. Thank you.
Thank you. Mr. Chairman.
Madam Chair.
Quick question, and thank you for being here today. Thank you for coming out of retirement. Thank you for many years of service in different roles to the great state of Texas. And Rob Janelle, I had an opportunity to serve with him in the House. That certainly dates me, but he gave me a lot of good lessons as well. I actually sat in on the Appropriations Committee. I was not named. I was a freshman, and so I sat there day after day just to watch what was going on in House Appropriations Committee because I was fascinated by the process. A lot of good lessons from him. On your 9 state audits, are those financial or performance audits?
They're both. We had 2 financial audits, and we had 7, and then of the 7, there were 5 wrapped up into 1. So that it's both.
And who's performing the audits?
HHSC, and then financial, that would be an independent financial company.
Excellent. Thank you so much.
You bet. Thank you.
Melissa.
Okay. Good morning. Thank you so much for allowing me to testify this morning. My name is Melissa Shear, and I am the director of the Travis County Mental Health Public Defender. I am speaking today not on behalf of the county, but on my own behalf. In addition to my role, I'm also the mother of a 24-year-old individual with autism and bipolar disorder. And this is not relevant to this issue, but he's been on the interest list since he was 18. So still a long way to go. I'm here in full support of Senate Bill 26. I feel like it's going to make significant strides for Texans in terms of getting transparency and in the provision of mental health and substance use treatment. The first section I would like to highlight is the incentives for nursing homes that will equip themselves to serve people that have medical needs and also have a serious mental illness. Over my 16 years in this role, we have struggled when we have an individual that's medically fragile and has mental health needs. We've struggled to find nursing homes that are able or willing to give them a place to stay. The second piece, I'm really pleased about the performance contract audits. There has to be much more transparency with the local mental health authorities about the funds, the public funds that are spent on services. It's been very difficult to get information about what kinds of services the performance of different kinds of services. And it makes it difficult for us to know whether certain programs are working or not, or whether we should be investing in something else. So I appreciate those audits. Also, the joint discharge planning, that's huge. I've had many clients that have walked out of a state hospital and are given an appointment at the local mental health authority as their plan.
Thank you, ma'am. You got any real quick finish up or?
Yes. So on the last section that I want to talk about is the public reporting system. Very much in support of that. I would recommend that you add some specifics to the measures like Lee Johnson mentioned, but specifically to make sure that that there are denominators with the measures, because I've seen a lot of data in which it says like 99% of people successfully were diverted from jail, but we don't know what the universe of those people was. We don't know any demographics about them, so we don't know 99% of what.
All right, and I'm glad you ended in that point. I had a couple of questions for you. I know you're not here in your official capacity, professional, but I do want your perspective because you're the front row seat to the doorway to some of the conversations we're having today. Do you know what percentage of your clients that come through your process are served by LMHAs or the LEDAs?
At least 90%. We serve only people that are indigent.
So, and then do you track the recidivism data of those people that are kind of repeat offenders?
We do. From our office, we track it.
What is that number? Do you know?
Well, it varies, just depending on. We've reduced recidivism. I don't have the exact data right now, but we have reduced recidivism. The difficulty that we have is that year over year, services that our clients can gain access to change.
Okay.
And so when there are certain programs that are effective in helping some of them, and then next year they're gone.
So are they changing because we think we have a better mousetrap and we keep pulling the rug out in hopes of a better process, or do we change because of lack of funding or lack of provider? What is it, all of the above? Or?
All of the above. I think one of the big changes is that when a level of care is calculated for a person, sometimes they qualify for the highest level of care, which is the ACT team level of care 4. But because there are not enough staff to provide that resource, they're put in a lower level of care, which means that they're not getting the level that they qualify for.
Yep.
And that some of the data that we're missing is knowing how many people are, qualifying for that higher level of care and are not getting it because we don't have capacity for it.
Penny saved and a pound foolish? Penny saved and a pound foolish?
Yes.
Madam Chair, did you have questions?
I have one question. Thank you for coming today. I appreciate your role as a public servant in Travis County, but also as a mom.
Yes.
I know how difficult that can be. We all love our children, and some of us don't face the same issues you do, and I just can't imagine that.
Yeah.
So thank you so much. Do you serve clients today who would qualify and may need potentially an SSLC or something of that level?
Absolutely. The people that stay in the jail the longest, because of either mental health or IDD, it's the people with IDD, because there are not placements for them, there's not crisis respite for them. So yes, that population we serve plenty of them.
And so, it was interesting that just this week I had actually an HCS provider, and he has private ICFMRs. He's the benefactor of the waiver system, and he actually said to me, unbeknownst to some of our hearings that we've had recently, that he's like, we absolutely some people need the level of care that an SSLC can provide, which is the highest level of care. So again, I look forward to working. There are a lot of things moving here, but we have gatekeepers that decide where people get their services or not. Is that a proper level? That's a recurring theme that we're hearing. And then also the state has made a substantial investment in some of our settings that I think are underutilized as well. So
right. And if I could just add about the SSLCs, I have had clients that have requested to go to an SSLC. They've been there before and were discharged into an ICF group home in hopes that they could transition to the community, but were later arrested there and have requested to go back to the SSLC because they felt safer there and were not in a position where they were being arrested and things like that. So.
Well, thank you for your testimony. We're going to try to pass a bill to fix that a little bit. And we need that kind of input. So the LIDAs are our gatekeeper in that regard. And I think, as much as I'm focused on LMHAs right now and making sure it's transparent with the amount of money we're getting and are the services being met, are we not funding enough? What we also need to look at our gatekeepers. Thank you so much.
Thank you.
Thank you for being here. Thank you for your testimony. Members, is there anyone else wishing to testify on, for, or against Senate Bill 26 publicly? Sheila, you're not registered, man, publicly. I've texted you 3 times. Get up here. And then you register publicly when you get done. I've not got you on any bills today. I don't know what's happening. Somebody needs to work with you on that button.
Thank you.
State your name and who you're with in 2 minutes, and then when you get done, go back and change it to public testify.
Does everyone have their copy of this document?
No. We're not on that. Need to pass those out, sir. And you need to check and see why her registration's not working, because she's not on any of the bills, and she says she's on all 3.
Sheila, are you registered on 26?
Yes, ma'am. 26. Yes, ma'am. Innovations. I want to be on your train, Senator Kolkhorst.
Okay.
Train's moving. Go ahead, Mr. Chairman.
All right. State your name, who you're with in 2 minutes.
My name is Sheila Hemphill with Texas Right to Know. I'm very grateful for Senate Bill 26. I am asking at the top of this document, you will see I'm asking for an amendment to Section 535.004, use of grant money. A grant recipient may use grant money awarded under this chapter to develop innovative strategies that provide, with the proposed amendment of number 5. I'm sorry, evaluation.
You're okay. Take a deep breath. You're fine.
Evaluation, testing, and treating of physical root causes that manifest as psychiatric dysfunction. I'll say it again. I'm going to pull it together. I've been at this since 2018, trying to bridge the chasm between physical medicine and psychiatric medicine. It is so broken and so divided. It is essential that we evaluate, test, and treat for physical root causes that manifest as psychiatric dysfunction. In this example, which many of you have seen for years, the handwriting on the left is from a 12-year-old little boy who'd been seen by 5 specialists, had 11 diagnoses, and was on 8 meds. The handwriting on the left depicts chaos in the mind, in the child, in the schoolroom, in his family, in our society. He had received the psychiatric treatment, the 8 meds. It was not until he got to a physical evaluation to determine the child had nutritional deficiencies, fungus, lead, and lead.
Finish your stop.
You will not counsel out socially or behaviorally the chaos that is created in our bodies that can even come from the psych meds that are supposedly to treat the chaos. I personally have had a diagnosis of manic depression starting in 1990. I've had 5 episodes and 3 hospitalizations. I have been off medication successfully, and I think after years of testifying before this committee, I think I would be categorized as pretty high function.
Yes, you are, and we thank you for your persistence. Any questions? Senator Hall.
Yeah, it's as much a comment as a question. We know that mental illness is growing significantly. In our schools, I had a conversation with about a dozen superintendents a couple of months ago, maybe it's a little longer than that now, and they wanted to express their major concern in schools, and they all agreed that it was violence in the classroom in our lower grades. And as we see this growing, I see a lot of talk about what are we going to do about people with mental illness. I don't see much action being put into why do we have this problem? What are we doing now that's bringing this out? We keep looking at, and I don't disagree with anything we're talking about doing at all. It's that our solution seems to be we've got to have more beds. And I hear so very little talk about, is there any chance we're doing something wrong in the early treatment or the lack of early treatment? I mean, it's like with COVID. We realized that trying to wait till people really got sick was too late to treat them for COVID when we could have treated them early and they survived. Is there any way that we can do more to take a look early on when people are starting to show these signs? And I know mental illness is such a stigma that nobody wants to jump up and address it. But I think we've gotten to the point of the rate of growth of the problem we have that we've got to do more on the front end of this and look at what is causing it. Are our treatments the right, like what Sheila's talking about? Maybe our early treatments, because we've done them before, we're just doing them more, but maybe that's not what's working. So I just like to say that somewhere along the way that we put some consideration into trying to get ahead of this and prevent or bring it to a head or cure it early, as opposed to just waiting and building more beds. Thank you for letting me.
Thank you, Senator Hall. And it's complicated, and I don't understand quite the growth. And it's so multifaceted. It's environmental. Part of it's just people are truly struggling differently than they used to, but I wish we had that answer for sure.
Senator Perry, I believe you've observed a trigger in me.
Yes.
Mental health bills
Right.
are a PTSD trigger. I come here hyper, the lights, sounds become intense, and I went through the process to register, and I may not have missed that check or that finish.
And I appreciate that, and we're going to fix that. So,
Well, no,
Thank you.
that shows what can happen in classrooms.
right.
The struggle in this chaotic state.
I hear you. I wish I had the answer. I
Well,
really do.
one, they should start requiring psychiatric physicians to accept medication from primary physicians in psych wards. They will not prescribe it because in the psych ward, the psych doctors are only aware of psych meds. They have to
hear you.
discharge to get to their doctor who
Maybe
oftentimes-
some, I appreciate you.
Sorry, thank you.
No, you're fine.
Thank you.
Maybe someday we have an interim over early medication versus other alternatives and things. So,
Thank you.
I do believe that is all I show testifying publicly on Senate Bill 26. Is there anyone else wishing to testify on for or against Senate Bill 26? Chairs none. Public testimony is closed. Bill would be left pending.
The chair recognizes Senator Miles as being present. Thank you. Members, we're going to lay out two or at least one other quick bill. Members are having to leave to go vote for some bills in some other committees. And so, Senator Blanco, I'm going to pass the gavel to you. We'll lay out Senator Middleton's bill. And then members, we're going to vote certain bills out when we come right after recess off the floor because of this movement we have this morning. So,
Madam Chair?
Yes.
Since we're so close to recessing, and I'm really interested in Senator bill, is there any chance we can just go ahead and recess now?
We're going to do Senator Middleton because he's got one, he doesn't have any witnesses right now, and he's got to lay out a bill this afternoon. And then we'll come back right after recess, if that's okay.
Okay.
The Chair lays out Senate Bill 177 and recognizes its author, Senator Middleton, to explain the bill, and I understand that there's a committee substitute. Senator Middleton sends up committee substitute. The chair lays out the committee substitute in Senate Bill 177 and recognizes its author, Senator Middleton.
Thank you, Chairman. Members of the committee, COVID vaccine mandates have no place in the great state of Texans, and no Texan should have to choose between their sincerely held beliefs on the COVID vaccine and their right to make a living and feed their family. Informed consent is the foundation of the doctor-patient relationship. As an established in the Supreme Court case Canterbury versus Spence, informed consent has ensured that patients are aware of the benefits and the risks of a medical procedure before providing consent. So Senate Bill 177 requires healthcare providers to obtain informed consent before administering an FDA-authorized COVID-19 vaccine. The bill deems that a person cannot grant informed consent if they are compelled or coerced into getting the COVID vaccine against their vaccine preferences. The bill prevents adverse actions or penalties being imposed against individuals for refusing to receive a COVID-19 vaccine, and this represents a critical protection for working Texans that fear retaliation for making a personal medical decision. I have many personal stories from constituents facing threatened loss of their jobs who are refusing the COVID-19 vaccine. One of them was a nursing student in his final year of residency, and he had a history of blood clots in his family and was worried about getting the vaccine and being faced with losing everything, his entire education and his career. And I know we've all heard heartbreaking stories like that. And this bill empowers the Attorney General to bring a suit against individuals in violation of this bill. A court is authorized to issue an injunction and take steps to prevent repeat violations. And patients subject to a violation will be entitled to damages up to $5,000, including reasonable expenses and attorney's fees from the healthcare provider that administers the vaccine against their consent. No private cause of action against businesses is in this legislation, and as we know, Governor Abbott already has an executive order that bans COVID vaccines for every entity except CMS. There's been a bill that has been passed in the U.S. Congress as of the January 31st, 2023, that would repeal all COVID vaccine mandates. And there are actually 14 states right now that have passed some sort of COVID vaccine mandate ban. So this list is growing all the time. I know a number of states have laws working their way through their state legislatures that would add to that number of 14. And this bill ensures medical freedom and that Texans should not be forced to take a vaccine, especially one that doesn't make epidemiological or medical sense. And, you know, I wanted to point one thing out, too, about the liability right now associated with the COVID vaccine. So there's a federal act called the PrEP Act, and what that does is it absolves employers and makes them protected from any liability arising from the COVID-19 vaccine. And a lot of my understanding don't even have insurance on that. And then also last session, we passed Senate Bill 6. And Senate Bill 6 is, of course, only effective while we're in a declared disaster, which we still are right now. And what that bill does is it heightens the standard to hold a medical provider accountable or for damages if they administer a COVID vaccine. And it's significantly above what the current liability standard is for informed consent. So it raises it to reckless or willful. Additionally, Senate Bill 6 absolves vaccine manufacturers from liability. So we're faced with this situation where we have federal and state law where the employer, the vaccine manufacturer, and the healthcare provider providing a vaccine are essentially absolved from liability. So this is a whole other reason why this bill is so important here today. And the committee sub fixes one drafting error that we had. We strike the last sentence in paragraph G, which was the heightened requirement for exemplary and punitive damages. That was just a drafting error. So that's what the committee sub does. It strikes through that and restores that current provision in the Civil Practices and Remedies Code. So with that, I yield for questions.
Thank you, Mr. Senator Middleton. Senator Sparks sends up the committee substitute, and the chair lays out the committee substitute, and we've just heard from Senator Middleton explaining the substitute. Members, any questions for Senator Middleton? No questions. Senator Miles.
Thank you, Mr. Chairman. I've got so many questions, Senator, on this bill. But I want to summarize it, just make sure I get a clarification. Even if the patient's vaccination preference is contrary to medical sound advice, the provider could still be penalized for encouraging a patient to who receives a COVID vaccination. Is that the way that I'm reading this right?
Right. So informed consent is already the law right now. In order to be in Medicaid, you have to provide that fully informed consent without negligence. So in other words, making full disclosures of the benefits and the risks associated with a medical procedure. So that's already the law right now. And what I believe would happen under this bill is they would just track the language in the bill that you are not being coerced, you're not being compelled to receive this vaccine, and then in a written attestation, you sign on the dotted line, and that is obviously a defense, or would be a defense, to a claim that you received a vaccine against your will.
So often medical assistants are the ones who administer the vaccination, is that correct?
Sorry, I couldn't hear that.
Often medical assistants are the ones who give the vaccination.
Right, that's correct. That's correct.
Okay. So medical assistants operating under the supervision of a physician. And if the physician orders the vaccination to be administered, is the medical assistant solely liable for the administration, or is the physician liable for the order of the admission? And under this bill.
So typically best practices is with informed consent that there's a witness there as well. Of course, this would apply to someone that has given an employee a directive. And informed consent is something that is the bedrock of our medical industry and medical practices and medical freedom at the end of the day. So this would require heightened informed consent. I believe that would be the outcome of this legislation, is that there would perhaps be better disclosures under the law as limited to COVID vaccines. Not all vaccines, just COVID-19. This only applies to COVID-19.
Just COVID-19? So.
COVID-19 only COVID-19.
So I hate to go into personal philosophies and philosophical. Were you a believer in the COVID vaccination? Did you believe?
That is up to each individual. I believe that's up to each individual and their unique medical history and risks, and that's not for me to decide for someone else.
Thank you, Mr. Chairman. Thank you, Senator.
Members, any other questions for Senator Middleton? Thank you. We'll now hear invited testimony on Committee Substitute Senate Bill 177, and the chair calls Jackie Schlegel, Texas for Medical Freedom. Please state your name and who you represent for the record, please.
Hi, sir. I am Jackie Schlegel, and I represent Texans for Medical Freedom and myself. I am the Executive Director of Texans for Medical Freedom.
I'm sorry, can you pull the mic a little
Yes,
closer?
sir.
Thank you.
The echo, it's just a little echoey.
Thank you.
I am the Executive Director of Texans for Medical Freedom, the state's largest and most active nonpartisan medical freedom advocacy organization. Texans for Medical Freedom is a member-driven organization dedicated to educating and advocating for all Texans' right to informed consent and vaccine freedom of choice. We represent our diverse supporters who share our values with dignity and respect. We empower individuals to become politically involved, ensuring that our freedom of vaccine choice remains a right that is free from consequence or interference from government or bureaucracy. It is with these principles in mind that we support Senate Bill 177. Why is this bill needed? All across the state, students, healthcare workers, and employees are being forced to take the COVID-19 vaccine against their will, despite significant developments concerning the safety and efficacy of these vaccines. What does SB 177 do? This bill would protect rights and liberties of Texans from being forced to receive a COVID-19 vaccination against their will. It protects an individual's right to informed consent as it relates to the COVID-19 vaccine. The British Medical Journal recently published an analysis on the effectiveness of COVID-19 vaccine mandates. They concluded that vaccine mandates are a bad policy move, stating that, quote, they have unintended harmful consequences and may not be ethical, scientifically justified, or effective. I believe they sum this up, the far-reaching problems with mandatory vaccination policies very well when they conclude that, quote, mandatory COVID-19 vaccine policies have had damaging effects on public trust, vaccine confidence, political polarization, human rights, inequities, and social well-being. We question the effectiveness We question the effectiveness and consequence of coercive vaccination policy and pandemic response and urge the public health community and policymakers to return to non-discriminatory, trust-based public health approaches. Thank you.
Thank you. Members, any questions for the witness? Thank you very much.
Thank you.
We'll go ahead and leave this. We have no more. Oh, no. Okay, we'll go ahead and leave this bill pending until we take up public testimony later in the hearing. It is the chair's intention to reconvene in 30 minutes upon adjournment and recess of the Senate. Testimony and discussion will resume at that time. Members of the committee stands in recess subject to the call of the chair.